Good evening, everyone. Thanks for joining us today. I'm Maryam Siddiqui, and I am the Section Chief for General Obstetrics and Gynecology. I have a busy general OBGYN practice, and I'm here to talk to you guys about breast masses and breast pain, which is a pretty common complaint that a lot of patients come in with. And I wanted to approach it from how we can approach it as a team to give our patients the reassurance that they need sometimes and sometimes escalate their workup to get them in to see the specialists and to see if they have what they're really worried about is this cancer? I will start with my slideshow and hopefully it all connects pretty clearly. Can you guys see the big slide? Does it look okay for you?
Not yet.
Okay. Let's see. Let's do the share. Hang on, let me see. Do this. 1 second. Um, I think I have to go into the Zoom, share. And I'll do desktop too, share. You're going to see my screensaver for a second, and then how does it look now?
You're good. Thank you.
Okay, perfect. All right, everyone. So we're going to get started. Our learning objectives today is how do we work as a team and how do we approach patient complaints that are focused on breast complaints like mass or pain. And then a little bit about using that as an opportunity to discuss breast cancer risks and to do an introduction to breast cancer risk assessment tools. It's a really great opportunity for us to approach that with our patients. If we have time, I'll do a little bit of a breast density overview because we see that on all the reports and it's a little bit confusing as to how that should be followed up and if they should have supplemental tests. I have no financial disclosures and we'll move ahead. Okay. My motivation for this topic, these are two very personal situations that really, kind of motivated me to pick this topic to talk about. One is a patient of mine. She's 70 years old. She's been a patient of mine for many years. She called in to get an appointment, and we go through a central scheduling process. And she called and she said, "I have a new breast mass." And my next available appointment was a couple of months away, and she was given that appointment. She's a very polite lady, and she took that appointment, and then 3 months later showed up. And I was very distressed to find that she had a mass, and that mass ended up being cancer. So my motivation is how can we do better for a patient that had a recognized issue and should have been seen much sooner. We've done some work around systems so that non-clinical people don't have to make these decisions on their own. So one thing we've done is created a nurse escalation protocol for urgent type of visits. So if somebody said, "Oh, I have postmenopausal bleeding," or someone else says, "I have a new breast mass," then we would get them in within a couple of days, and that call would go out to the nurses to work on. And then the most recent thing that we've implemented is in the scheduling software to make a set of reasons that are urgent reasons that don't need any clinical clearance, that they go right into an urgent slot, and all the providers have some urgent slots on their schedule. So this is to remove any barriers or delay to care. So while it will help the next patient come in with this complaint, unfortunately, this patient did have some delay in getting in to see us. And then my second motivating patient is a 33-year-old who was breastfeeding her 6 month old and thought she had a clogged milk duct and thought she had mastitis, took a couple of rounds of antibiotics. The mass was getting bigger, it wasn't getting better, and she came in for evaluation. And unfortunately, she was also diagnosed with a breast cancer. So, just to say that this can present at any age, we just have to be vigilant, we have to be alert, and we have to be available for our patients. And that is part of all of our jobs, not just the providers, but also all of the valuable members of our teams, including our medical assistants and nurses who are joining us for this talk today. Um, Really common. So, breast masses, 25% of all women will have a breast issue during their lifetime. The most common complaint will be a breast lump. While a new breast lump is very scary, and it is actually the most common presenting symptom of breast cancer, we know that most breast cancer is not diagnosed based on a lump. Most breast cancer is found on mammography, on screening tests before it becomes a lump. But if a patient has some symptom of breast cancer, and the symptoms of breast cancer can include masses, it can include discharge from the nipples, it can include skin changes, or very rarely pain. The very most common one of those to actually be a cancer is a breast lump. However, not all breast lumps are breast cancer. So only 10 to 20% of new breast lumps are going to be a malignant. And this changes with age. So like a younger person, it's less likely, maybe 1 in 200 of those people in the 30s, a breast lump is going to be a cancer. More often, it's going to be a benign process. And then as you get older, it becomes more common, but still it doesn't reach more than 3 to 5%. Breast masses deserve and warrant, in most cases, a triple assessment. The very first and most important thing is get them into the office so you can see them, you can elicit the important parts of the history, and we'll talk about red flags. And we can do a physical exam, and we'll talk about physical exam findings that can be worrisome. And then, of course, the next two steps are imaging and often biopsy. So here we go with the red flag symptoms, okay? So these are things that we want to find out from patients in addition to their lump. Are they also seeing some of these things, or are they seeing some of these other symptoms in isolation? So lump or thickening with or without pain can be worrisome. A change in the size, shape, or appearance of the breast. So if one breast all of a sudden feels bigger or heavier or looks red or feels different, that can be a signal of something going on. And some changes in the skin are really important. So dimpling of the skin can be an important finding. And we'll look at a picture of this classic finding called peau d'orange. And then redness or pitting, a rash that isn't clearing up, that's crusting, that's on the nipple, that's not healing, can be a warning sign. A change in the nipple appearance. Now, all of a sudden, you always had everted nipples, and now you're seeing one nipple is now inverted, or you're seeing the skin in the nipple change, or there's a dimpling in there, or a retraction. That can also be a signal that there's something going on deeper, or a new or abnormal discharge from the nipple. It can be even clear discharge, or it can be bloody or other colors, but we do always want to ask about discharge because that can be an important physical complaint as well. So here we have a really nice picture showing a couple of findings that are important and warning signs for breast cancer. And one of those things, just starting with this like overall, you see that the whole breast looks kind of edematous and swollen, and you're seeing each of these pores outlined. And this edema with the prominent pores and the look of like the skin of an orange is the finding of peau d'orange. And this peau d'orange finding happens when there is a cancer inside the breast that is invading into the lymphatic channels. So the lymph nodes and the lymph drainage is impaired, so there is some secondary swelling, and then the swelling creates these divots, and you can see those changes. Additionally, you can see this nipple or areolar complex. The areola seems to be, kind of moving inwards, and the nipple itself seems to be retracting. And you can see that this is probably not her natural or usual nipple shape, and a patient would be able to tell you that, like, this is a change. And this happens because there's a mass deeper inside, and you can see in this graphic here, there's going to be a mass deeper inside that is scarring and causing fibrosis of the connective tissue inside the breast, and it's pulling everything back, and that is why you're seeing this retraction of the nipple. Other findings that you can see is when you're doing an exam on the patient, you actually want to do the exam in two different positions. The first position, you want to have the patient sit up. You want to have them put their hands at their hips, and you take a look and you see, okay, well, do the breasts look symmetrical more or less? Do you see any kind of abnormal contours? Like you can see in this breast, you can see a kind of outpouching. And then when you examine the patient, you want to also extend that exam into the axilla because the breast tissue does extend up into the axilla. It's called the axillary tail. And in the seated position, you can actually place your hand deeper inside the axilla, and that will facilitate for you to find those lymph nodes or any swelling related to lymph nodes. You also will look in the supraclavicular area and feel your nodes up there, and that's all while the patient is seated. Once the patient's laying down, you can see on this exam, like this patient is laying down, you can see that there's some dimpling, there's a mass on the side. You may also be able to more carefully inspect the nipple areolar complex and see if there's skin changes. And those skin changes with like crusting and erosion and non-healing skin changes can signal Paget's disease of the nipple, which can indicate a cancerous tumor or DCIS deeper inside. So those are all the things that we are looking for on the exam. Breast masses can be besides cancer, they can often be, especially in younger women, benign things. And so this is a listing of some different benign tumors that you can find in breast on a breast exam, either on a patient that has a self-appreciated exam or something that you notice. So they're classified by non-proliferative and proliferative, and there's some other types of tumors as well. So we'll just go over some of the common things. The most common thing is a simple breast cyst. Lots of women, the majority of women will find a breast cyst at some point in their lives. And these are usually simple. They're usually like 1 to 2 centimeters. They can be mobile. They can fluctuate in size, go up and down. They can be responsive to hormone. And on an exam, it's hard to distinguish between something that's a cyst, which is a fluid-filled collection, versus a solid mass. You can't always tell with your fingertips the difference. So then that's where the imaging part becomes really important. And we'll talk about how to choose which imaging depending on the patient's age and complaints in a couple of slides. Other things these are called non-proliferative. So this is just normal cystic fluid within a cyst. It's not a proliferative mass. And then you can have proliferative breast lesions where there's like normal tissue, like the epithelial and stromal components of the breast that's just amplifying and growing, but it's not malignant or atypical in any way. And this does not increase the risk of cancer. These are also very common, and these can show up. The most common type of this is a fibroadenoma. You want to think of like a bouncy rubber ball consistency. It's mobile. It has a very good border. You can delineate the whole thing. If you press against it, it will slide underneath your fingers and move in the breast tissue. And these are all reassuring findings. It's mobile, it's well circumscribed, it is a small size, and these are 1 to 2 centimeters, and you might find them in menstruating women and mostly in adolescents and young women. Another thing that you can see in the category of proliferative breast lesions is sometimes more common to present with a breast discharge or a nipple discharge, usually unilateral, a lot of times bloody or black, and sometimes you can appreciate the mass in the duct. That's called an intraductal papilloma. That usually the masses are smaller, 2 to 4 millimeters, but they can be bigger and they may present as masses, but often they will present as nipple discharge. Some other masses you may see are tubular adenomas. This is not something that you're going to be able to, at your fingertips, distinguish. There are always things that you can feel better than you can see, and then there are other things that you can see better than you can feel. And so the imaging is really important to figure out, is this solid or cystic? And then the biopsy is really important to figure out, is it a usual type fibroadenoma? Is it a lactating adenoma? Is it something malignant or nefarious? So all of those things play a role, like we talked about in the triple assessment. Another type of benign tumor, and mostly benign, is a phylloides tumor. Phylloides tumors are really interesting because they are extremely rapidly growing, so that can be alarming to patients, and they will be usually a bigger mass on initial inspection, and it is usually a little bit older age, like in the 40s. When you biopsy them and the biopsy comes back phylloides, the treatment is actually excision with a good healthy margin because they are really notorious for recurring. So you want to make sure you get a good margin, otherwise they will locally recur even though they're not a cancer, and they will rapidly expand again. So those are all some of the benign things that we can find on a breast mass. And there's some other things like a breast hematoma is another one, and some other less common findings for breast masses. So now switching gears just a little bit, and we're going to talk about breast pain. And breast pain is also a really common reason for a visit. And when you see a patient with breast pain, something that you really want to distinguish early in your evaluation is this something that's cyclical? So is this something that is happening for the patient on a monthly basis? Can they tie it to when they have their period? As we know, a good portion of our patients might have an IUD that they don't know if they're having periods, right? So are they able to keep a calendar and say, oh, around the 20th of each month, I start to notice for a week that my breasts are tender, and then about a week later, I feel fine. Well, that would be defined as cyclical breast pain or cyclical mastalgia. Non-cyclical is exactly the opposite. Like they can't tell when their pain is coming. It can be intermittent, it can be constant, it has no pattern that's distinguishable. And then the last reason for breast pain can actually be extramammary, which means like it's not related to the breast. They're feeling it in the breast, but it might be related to some other processes going on, and we'll go over those. People come in for breast pain because, yes, it can interfere with physical activity or sexual activity. It can be uncomfortable, but mostly a fear of cancer is a really big motivating factor for patients to come in and need evaluation for this complaint. Cyclic mastalgia, like we talked about, this is really related to hormonal fluctuations. The breast is sensitive to estrogen and progesterone, and particularly estrogen can have breast pain kind of a manifestation. Think about like early pregnancy when all your hormone levels go up, and people often will say, oh, well, my breasts feel really tender in their first pregnancy. Another time might be when they first start birth control pills or menopause hormonal therapy. Those are also times when people feel like that hormonal effect. But naturally, in our bodies, if we're not on any of these medications or in these conditions, you can have cyclical breast pain kind of alternating with around the luteal phase, so the couple of days to a week before you get your period. So the typical pattern, it starts about a week before, it gets better after menstrual flow. Some people might even notice like if the breast feels swollen in both upper outer quadrants. That is particularly in people with fibrocystic breasts. They notice that those type of changes. This is interesting because it gets worse in the 30s and 40s. So younger women might feel like, well, I have never noticed this, and all of a sudden I noticed this change. And so it is nice to reassure folks that when you figure out that it is cyclical breast pain, that it is, it happens with age, and it may not have been an issue when you were younger. It can resolve on its own often, but it can also persist despite treatment. So it is a little bit tricky on how to treat that, but it is something that you can, with good confidence, reassure your patients that it's not something dangerous to them. Non-cyclical mastalgia is only about a third of people with true breast pain are going to have the non-cyclical variant. And like we talked about earlier, it's not intermittent or constant, so it's less likely to respond to like changing your hormonal therapy or something like that. That's not necessarily going to make it better. It can also be unilateral. Typically, cyclical breast pain is going to be on both sides of the chest, but like unilateral pain might be more of non-cyclical mastalgia. This is women that are in their 40s, 50s, and in the perimenopausal phase. Again, a good rate of people are going to have resolution on their own. You may need to review their medication list. There are a lot of medications, pretty common medications, that can actually cause breast pain at the time of initiation and also when people are continuing. So a lot of people are on diuretics. Some people are on spironolactone, which is a really common medication we see in the OBGYN space. Like we talked about birth control pills and estrogen replacement. SSRIs can do it. Thorazine, which is a very common agent people use sporadically to help them sleep, that can also cause breast pain. And then some of the antipsychotic medications, mainly because they drop the dopamine level, which can then cause the prolactin level to go up. And the prolactin might be part of the reason that you're having breast pain. And a rare cause, and there's a nice graphic here from Netter of something called Mondor's disease, where you get a superficial thrombophlebitis. Think of somebody like who has had like an IV started and the IV got a little, you got a little superficial blood clot in that area. How that is tender, you can feel that cord, you can see it. It's dark blue, you can see it, you can feel it, and it is exquisitely tender. So this can also happen on the breast, and that's called Mondor disease. It can, though, however, sometimes be associated with an underlying malignancy. So you do have to be careful about that and really order the age-appropriate breast imaging if you do notice a blood clot, even a superficial blood clot at that area. And last, extramammary breast pain. So this is somebody might come in and they say, I have a lot of breast pain. And when you're examining them, you might notice that the pain is right here where the ribs join the sternum. And that's a costochondritis. So if you don't see any swelling and it just pressure in those joints and areas, then you can reproduce the pain, then that's usually costochondritis. And it can happen after a URI or a long-standing cough. Those are all things that can predispose you. If you start to see though some swelling in the joints and you see like more of an arthritic type of look, that's the more rare version of costochondritis called Tietze syndrome. And it is managed the same way, nonsteroidals, and either topical or oral nonsteroidals can help decrease the inflammation at those joints. Zoster can present with breast pain because before you get a rash, you may actually start to notice a lot of pain on one side, so unilateral breast pain, and then a couple of days later the rash shows up, and then very quickly people can figure out that okay, this is zoster, and I need to start taking my antivirals before this becomes a long-standing thing. So post-herpetic neuralgia for people who aren't adequately vaccinated for shingles or rapidly treated for a zoster outbreak can have long-standing pain consequences in the dermatome of their flare. So another reason to really focus on getting people vaccinated for shingles, and now they changed that recommendation to over 50, and then also starting them on their antivirals very quickly after they present. Chest wall trauma. So let's say you were in a car accident, seatbelt deployed, you might have some fat necrosis, you might have some bruising. So a lot of times people will come in because a kid or a pet kind of jumped on them and they may have breast pain from something like that. Obviously we do always want to have in the back of our mind any kind of like red flag or spidey sense for is this patient safe at home? Is there a question of any kind of violence against her? And being sensitive to considering that as another source of trauma or pain. Rib fractures can also be part of it. Cervical radiculopathy. So if you have like a pinched nerve and some of that pain is wrapping around, you may also have some pain originating from other places. And angina, of course, in women, we know that heart attacks and angina don't always present with the classic crushing substernal chest pain radiating to the left arm. It can be more subtle. So, just having a high index of suspicion for something like that. Reflux or GERD. And then, of course, pregnancy we talked about as another reason that people might have breast pain. Right. So breast pain, this was a really interesting study done in the UK. So, in the UK, they have a National Health Service. Patients enter the system through their primary care and then get referred to specialists. And what they did is they looked at a group of almost 11,000 patients that had breast pain, but breast pain alone. So they had breast pain, they came to see the specialist, and they didn't have a lump associated with the pain. They had no skin changes associated with the pain, and they didn't have any discharge associated with the pain. And what they found is the rate of breast cancer was the same. 0.4% in the women presenting with pain alone and the women presenting just for a mammogram. So, like your routine, no complaint person going in for a screening mammogram. So, that was really reassuring. And in the UK, they use this to say that most patients with pain alone do not need referral to a breast specialist, but can be evaluated safely in a primary care office or with their OBGYN initially to rule out any kind of mass or physical finding that would prompt needing to be transferred to a specialist. And not to say that it can never, ever, ever present with breast pain, but like you do also want to understand that a patient with breast pain does need an evaluation. And so they do warrant coming in and a physical exam and a good history, figuring out if there is some reason that they should and could get some imaging or referral. And if they don't have anything it's more cyclic, right? So you say, this is cyclic, this is a menstrual age person, it's a cyclic breast pain, it comes and goes, physical exam is fine, you can feel confident in reassuring that patient. And it's also but we talked about a really good time to introduce a conversation around risk assessment and are you at risk for breast cancer and what's your family history and so on and so forth and what are your exposures that are in your control. All right, so treatment approach to breast pain. Remember that we talked about that breast pain is actually a lot of times it'll resolve on its own. And a lot of times you'll try some of the treatments and it still persists. So it's really kind of a mishmash. There's not something that's like, this is definitively going to work. But I thought we'd talk about some of the general things in the treatment approach, what's in your basket of options. One is well-fitted and supportive brassieres. As we know, people's weight will fluctuate, their tissue will fluctuate. And I think sometimes people are committed to the bra size they are. They're just like, that's my bra size. And like their body has changed over, the decade or maybe even longer. And they just haven't gone in for that assessment again or gotten new undergarments to kind of reflect the changes in their bodies. And especially people who've had a lot of change in their breast tissue. So the people who have had lost a lot of weight on GLPs, somebody who has breastfed for a while and then stopped breastfeeding, their breast tissue might be different after they weaned, and they might need a different type of bra compared to what they were wearing before. And so starting with that, and then hot and cold compresses can be helpful. Dietary changes, there's a lot on the internet about this kind of stuff, about like avoiding caffeine and fat and salt, and especially during your luteal phase, and then the tannins in tea and chocolate. But that hasn't really borne out in the literature as effective methods of controlling breast pain. And like we talked about, a lot of times it does go away on its own. So like if you stop drinking coffee the week before your period and your breast pain started to get better, then you would, associate two things that may or may not be related. NSAIDs are always a good option, oral or topical. Topical NSAIDs are really good for patients that don't tolerate oral NSAIDs, but topical NSAIDs can be like Motrin gel or Voltaren gel. I know brand name is better than the other, but just to give people an idea of things that they can find over the counter, easily accessible and safe to use, which can help with pain as well. Uh, Evening primrose oil is another natural supplement. Some of my patients would prefer to try something natural or in the supplement group before trying something medicated. There's some studies also about iodine supplements as well to help with breast pain. And I'll talk a little bit about the iodine supplements later, but the evening primrose oil it has some interesting studies as well, and we'll go over those in just a moment. One option that the physician or the provider has is that you can also work with the patient to manipulate their hormone based medication. So let's say they are on a birth control pill or a ring or a patch, and they are just like, okay, well, I'm on the pill or I'm on the ring and I take it out each month or I take the placebo week. One option with the pill or the ring is to do continuous dosing. So you just go from one ring to the next and you skip your placebo week. And then same thing with the pill packs. You just go through like a 3 month at a time and only have one bleed every couple of months or no bleeds, no scheduled withdrawal bleeds. And that can help with people who are having cyclical breast pain as well as PMDD. Um, the menopause hormone therapy, if they're on depending on what dose of estrogen they're on, you might want to drop that down a little bit and see if that helps with the breast tenderness. We do expect when people start hormone therapy or start birth control pills or the ring that they do have some initial breast tenderness. That's an expected new start side effect, and then that does wane over time. And if it doesn't, then you might have to adjust some of your medications. The second line options, the prescription-based options like tamoxifen and danazol and bromocriptine, these are all medications that have significant side effects and are usually not well tolerated. Tamoxifen, very commonly used for adjuvant endocrine therapy in breast cancer survivors, hot flashes, joint pains, usually not well tolerated. Danazol is a weak androgen, so it is approved for breast pain. It is also helpful as an older medication for endometriosis because it will suppress estrogen levels, but as a weak androgen, it can have some untoward side effects too that people don't like. And bromocriptine, a lot of nausea and vomiting, that brings your prolactin level down. And like we talked about, those are all different hormones that may impact breast pain. And then iodide supplements, so like my patients that are interested in more of a natural approach. So the theory behind this is that your iodine is low and the breast tissue, like the thyroid tissue, is responsive to iodine. So they say, okay, so your iodide level is low in the breast, and then you give a supplement and that corrects the dose, and then that should help with breast pain. And it also works against some of the estrogen effect and modulates the prolactin effect on the breast. So that's the theory behind how it works. But you have to be careful with iodide because if you are taking too much or supraphysiologic doses and you have a predisposition for thyroid disease, you could unfortunately, you could set off in some thyroid issues for yourself by doing that. So that's something we should assess. Is there a family history of autoimmune thyroid disease? Is it safe for this person to take? You might want to do some blood tests before offering this as an option. And there's some older studies that say there's some improvement, but again, these are not like strong randomized controlled trials that say, okay, this really works. And so it's a little bit harder to get 100% behind this supplement. Although some patients may want to try, and the safe way to do it would be to like assess if they're at risk for any kind of thyroid disease before starting. So coming back to the evening primrose oil, so evening primrose oil, the seeds are really rich in omega-6 fatty acids, and in particular gamma linolenic acid, and that is thought to be low in women who have breast pain. And so you're adding back something that's low. And also, evening primrose oil is known for working against the inflammatory pathway, so it's an anti-inflammatory agent. And the studies, some studies were very promising, like, oh, this is pretty helpful. But then when they do a bigger meta-analysis and pool all the studies together and look at them together at a lot of patients, they do find that they are probably less side effects, but about the same performance as some of the other better studied medications like NSAIDs. And the issue with any of the supplements is what's the correct dose, what's the right duration, which formulations are accurate in what you're getting. So that's a little bit trickier to advise a patient on how to do that. But again, if somebody wanted to try it because of the pretty low side effect profile and danger profile, this would be a good first option for someone if they wanted to try. This was an interesting meta-analysis of a lot of different studies, like we talked about. And this is a forest plot. So a forest plot basically will place each study and what they found. Did it favor evening primrose oil or did it favor placebo? And they plotted out this, and the outcome of this is severity of pain. So yes, versus placebo, evening primrose oil was a little bit better in most of the studies. And then you look at, if you want to look at the outcome of evening primrose oil versus placebo in the outcome of like adverse events. So a placebo, like technically shouldn't have any adverse events. So you're seeing about the same. They're falling in that same category. So that's reassuring. And then evening primrose oil versus topical NSAID. So this is like your gels, your ibuprofen type of gels. And then this is like patients responding to treatment. And then it did favor the evening primrose oil on this. And then this is a more of an analysis of like, were the studies good? How good was the evidence? And they said, well, the certainty of the evidence for like patients responding to treatment is good, and the recurrence of adverse effects is good. So again, a good first choice may not, and without a lot of side effects for the patient who's more interested in a natural approach. Okay, we're going to do some questions, and I have a couple of people live on the call. You're welcome to answer the question if you'd like, or I can work through them. So no pressure. I'm not going to call on anyone, but you're welcome to chime in if you'd like to and make it more interactive. Okay, question number one. All right, and this will allow us to go through some of the algorithms in how to work up a breast mass. So a 29-year-old woman, she's coming in for a routine visit. And on physical exam, I feel a 2.5 by 2 centimeter right breast mass. It's irregularly shaped. So it doesn't feel like I can't feel all the contours. It's not smooth. It's not tender. It's kind of hard. And it's fixed to the underlying tissue, which means like as I'm trying to move my finger against it, does it bounce? It doesn't bounce. It kind of stays fixed on the underlying tissue. So just starting like way with just scoping out, am I having a high suspicion that there's something wrong or a low suspicion that there's something wrong? Okay. So I'm having a high suspicion. So I'm like, that makes me a little bit worried, right? So I feel like, okay, it's hard, it's fixed, it's not smooth, it's not regular. So that is making me a little bit anxious. So I want to get some imaging, right? So what's my next step? I want to do some imaging. I'm not going to do a biopsy without an image. So I'm giving you the answers as I'm talking. But what's the right imaging that you order in a woman less than 30? And the answer to this is actually ultrasound. So we start with ultrasound. So I'm going to go to the next slide. And okay, on this slide, we see this is from ACOG, but there's a lot of organizations that also use this as their algorithm. And this is palpable mass in a woman less than 30. And then the first question is, what's my suspicion? Is it low or high? And I said, I think I don't like the way this one feels. So I will get an ultrasound. So if I get an ultrasound and then they see a solid mass, then, depending on what other findings they have, it's a solid mass. It's got a lot of blood flow versus a little bit of blood flow. It looks complex versus it looks pretty homogeneous or smooth. That's going to grade it out as a more suggestive versus less suggestive finding, and that's going to lead you down the pathway to biopsy. But let's say I had a really low suspicion. Let's say it was mobile, it was smooth. She said, it comes and goes. It's like, I feel it more before my cycle. I'm about to get my period. Next week it'll be gone. Sometimes that happens on an exam. You feel something and they say, oh, I get that every month and next week it'll be gone. Well, then I have a little bit lower suspicion. I might observe for a couple of cycles, bring her back for an exam. If the mass is gone at a different time of her cycle, we're just going to keep following. If it persists, then we may get an ultrasound ultrasound there. So this is just a very good way for us to think about any patient under 30 and kind of work through that. Also, just you have a low threshold, right? So if you feel like I don't like what I feel or I'm worried about it, we have pretty easy ability to refer for consultation or for imaging. And you can start with the imaging or you can start with the consultation. Sometimes I'll order the imaging first and then route them to consultation as a second step. Um, oh, actually, there's another thing back here that I want to talk about. So, um, this is something, sometimes a scenario that happens. So let's say you feel something and you get an ultrasound, and the ultrasound says, hey, everything's normal. So the picture is fine, but your fingers told you you felt something, or the patient's fingers told you felt something. Depending on how suspicious you are and what you felt or their family history, you may continue to observe, or you may then escalate to the next level, either imaging or to see a breast surgeon. So your clinical judgment doesn't override, or clinical suspicion doesn't necessarily override a clean image. All right, this is question number two. We have a 45-year-old woman. She's got a painless mass in her right breast found while she was taking a shower. So this is the concept of breast awareness, not necessarily like every single month I'm doing a breast exam, which is a lot of us went through a time where that was the classic teaching. But now it's more about awareness. Like I'm aware that this feels different. I'm taking a shower. I feel something. I don't feel any other lumps. I don't have any discharge. I don't have any other complaints going on. So this patient is using condoms for contraception, so she's not on anything hormonal. She had breast implants a couple of years ago. She has a 20-pack year history of smoking, and she consumes 4 to 5 drinks per week. And on exam, you find a 3 by 3 centimeter lump in her right breast. And when we describe where a breast mass is, we should do it in a very standard fashion so we can communicate that out to our imaging team so they know where to look and to focus their ultrasound on, and we can communicate that out to our specialists. So we describe the size and where the mass is. Like if you think of the breast as a clock face, so it's at 3 o'clock, it's about 4 centimeters from the areolar edge, and that way it can be mapped out for the next person. And so on this exam, we find that the mass is hard in consistency. It's also tightly fixed to the underlying breast tissue. And then what's the next best step for establishing a diagnosis? So in this patient, we want to get an MRI of the breast, and that's because of the implants. So an MRI is a better imaging study in the context of a patient having breast implants. You're going to get better visualization. Now, if this patient did not have implants, your first step would be diagnostic mammogram plus the backup of an ultrasound. So you could look in both ways, because on a mammogram, you're going to see a mass. A cyst and a fibroadenoma can look the same, but when then you add an ultrasound is going to tell you what is solid and what is cystic, what is filled with fluid, and what is all a mass. So that would be the next step. Diagnostic mammogram and ultrasound is the next step in a woman who does not have implants, and then an MRI in a woman that does have implants. Sometimes when you do get a CT scan of, let's say you get a CT scan of the chest for another reason, let's say they have a cough or you are worried about something else going on in the lungs, they may report an incidental finding of a breast mass, and then if they do, then you go back to doing the diagnostic mammogram and ultrasound as a better study to look at breast tissue. So this is the algorithm for our palpable mass patient who is 30 years or older. This one always starts with diagnostic mammography, and then based on the mammogram, if it's a lower risk finding, then you do ultrasound next. If it's a higher risk finding, spiculated, irregular, a lot of calcification pattern, that would just warrant that would be considered suspicious, and then would warrant a tissue biopsy. And when patients get biopsies, they don't get fine needle aspirations. They really do get core biopsies, which is a bigger needle, a 16-18 gauge needle. And the purpose is to get enough tissue and architecture that you can really get a read on that. And an FNA or fine needle aspiration, while it is kinder and less painful for the patient, it may not offer the diagnostic certainty that you need at this point. So coming back to this, if it's less worrisome looking, less worrisome features, you would get an ultrasound as a second look, as a second thing. And if it looks like a cyst, so you felt a mass, it didn't look that scary on mammogram, you did an ultrasound, it looks like a cyst, you can just follow up. If it gets bigger or it's bothersome, you can drain it. If it looks solid, does it look solid and worrisome, or does it look solid and pretty benign? You can follow every 6 months for a couple of years, and then bounce them out to regular screening mammography. Let's say there's nothing. I don't really see anything on mammogram. I don't really see anything on ultrasound. Again, my clinical judgment is important here. Low or high clinical suspicion. And then if it's high suspicion, then you would send them to someone to get a tissue biopsy to figure out what it is. Why don't those things correlate, your exam and your imaging? All right. Two other questions here. 52-year-old woman presenting with spontaneous unilateral clear yellow nipple discharge. On exam, you feel a retroareolar mass in the right breast. And when you express, you do get some serous discharge. So is that high suspicion or low suspicion? I think based on age and the fact that there is some nipple discharge and a mass, these are all kind of worrisome findings. So I would have a high suspicion and probably move down the diagnostic pathway. And then we would do a mammogram and an ultrasound like we talked about. A 28-year-old G0, she's saying she has bilateral milky nipple discharge, but on expression. So she's like, oh, when I press or, when something presses against me, I'm noticing some milky discharge. This is new. She has a history of irregular menses. She started risperidol 6 months ago for atypical depression. Her last period was about 6 weeks ago. When you do her physical exam, you find milky discharge bilaterally on expression. There's no masses, there's no skin changes. What would you do next? So some of the things you might do is you might do a pregnancy test, irregular periods, milky discharge. Maybe this is a signal that she's pregnant. So you could do a pregnancy test. You should also, reviewing your medications, anything new. This is the key here is that she started a new medication, risperidol, which drops down your dopamine, which then causes your prolactin to go up and is one of those medications that can cause bilateral galactorrhea. This does not need imaging necessarily, but you might want to do some labs like a prolactin level or thyroid level just to make sure there's not something else going on. And your suspicion is usually pretty low for anything worrisome for galactorrhea. Imaging bilateral expressed galactorrhea is usually not something that needs imaging in younger women. All right, and so we kind of went through this one. I am at the 46-minute mark, so I want to leave a little bit of time for questions. So I'm going to skip past this. You guys will have these slides because I really do want to talk about this. This is really, really important. So as medical assistants and nurses, when you are with patients, one of the most crucial things that you do to help us is to ask patients and confirm their history, their family history. 1 in 4 women probably qualify for genetic testing to see if they're a carrier of a mutation that puts them at higher risk for cancer. And sometimes, even if they don't have genetic testing, their personalized risk assessment score does then put them in that high risk. So their lifetime risk is about 20% or more, and then they qualify by insurance to get testing like an MRI. So they don't just get a mammogram, but a mammogram, 6 months later, an MRI, and then 6 months later, another mammogram. So they're actually getting 2 screenings per year. And this Olivia Munn, a famous actress, actually credits the risk assessment tool with saving her life because she did the risk assessment tool based on her family history. She was not a genetic mutation carrier, but she did the risk assessment tool. She ended up being high risk, more than 20%, had an MRI, and they found a cancer before it was detectable in any other way. There's a lot of different risk assessment tools out there, but the most important thing is the family history and the patient understanding that that family history is one component of your individualized risk. And so there's a lot of different tools. I prefer the Tyrer-Cuzick because I feel like it is very comprehensive, and it is also good for minority patients as well. It may overestimate the risk in Latina women, but overall considered to be a better choice to reflect the different communities that we serve. There is a Black Women's Health Study cancer risk calculator. All of these tools are available online, and patients can calculate, can put in their own information and calculate them. Some institutions will include risk assessment as part of their mammogram report, which is also awesome. Okay. And these are some of the things that they measure on the risk assessment tools. The different tools ask different questions, but age, your ethnicity, your weight, your breast density. So people should know if their breast density is extremely dense or heterogeneously dense or not. Hormone exposure in terms of menopause hormone therapy, we know that the addition of progesterone to hormone therapy does increase the risk of breast cancer. How long you've been menstruating, age at your first period, age when you started menopause, your childbirth history, which is a protective factor, height and weight, like we talked about. And breast cancer risk, as we know, increases with age. Your life in general, the general population, about 13%, 1 in 8 women will be diagnosed with breast cancer. And then you can see the numbers getting smaller and smaller as you get older. The denominator gets smaller and smaller, and the risk of breast cancer starts to go up. Protective factors, just a couple of lifestyle type of things. So physical activity, independent of weight control, breastfeeding, if you are able to do it, weight loss in postmenopausal women, a low fat diet in postmenopausal women. These are all considered to be protective factors. Obviously, for our BRCA mutation or previous breast cancer or DCIS patients, being on tamoxifen or having risk reducing surgery or being on an AI in their clinical context might also be protective. Things that don't influence breast cancer risk. So this is also important, dispelling myths. Abortion, electric blankets, hair dyes, tubal ligation, IVF, caffeine, breast implants, antioxidants and chemicals. These do not influence breast cancer risk. And then things that are unclear. So maybe fiber intake is helpful, maybe a calcium and vitamin D. We don't know if those things are helpful. Some patients say, I don't want to do mammograms. I want to do this thermography or something else. And they may say, I'm worried about additive mammograms. If I get a mammogram every year between 40 and 75, do I increase my risk of breast cancer? That's not really shown to be borne out in the literature, but that is something that patients might bring up. But a mammogram is the better screening test than any thermography, I think is the name of the one that patients talk about sometimes. And unclear if night shift work has an impact. Some studies do say predominant night shift work does predispose people to diabetes, other metabolic conditions, and increase the risk of cancer. Although for breast cancer, those studies are not conclusive. Okay. All right, perfect. Dense breast supplement or not supplement. At University of Chicago, we do 3D mammograms. This is just a little bit of information on what ACOG says, the American College of Obstetrics and Gynecology. Their last statement of this was reaffirmed back in 2017, which is nearly 10 years ago. And they said that they do not recommend routine use of alternative or adjunctive tests, which means whole breast ultrasound and MRI. They don't routinely recommend, but you can have a discussion with your patients if you want to add that on. And then switching gears to the American College of Radiology, this is more recent information, and they are talking about average risk women with dense breasts. They say an ultrasound of the breast may be appropriate. So whole breast ultrasound may be appropriate as another way to look at dense breast, but there's a lot of disagreement. The way I explain it to my patients is a mammogram is really good if your breast tissue is mostly fatty or fibroglandular because it can compress, the mammogram can compress, and you can really see a pattern of calcifications or small masses. But when your tissue is dense, that means there is more gland than fat, and the gland doesn't compress as easily, so your visualization is not as good. And so you may miss things, which is why a second type of test might be helpful. So you want to assess, are these patients with intermediate risk, that 15 to 19%? Are they patients with high risk? And then based on that, you can look at these charts and say, like, what should I add on? Should I add on a whole breast ultrasound or an MRI? And then again, coming back to knowing your own individualized risk, what would be helpful as a next step for you, or is 3D mammogram sufficient? Right? That's what I have. Those are my references, and I open the floor to any questions that any of you may have or any clarifications. Thank you for joining me.
Well, first, thank you. And I need to go get my shingles vaccine. I was like, okay.
That's
Um,
funny.
I'm so glad you brought up the screening modalities. And Dr. Sarah Wagner had reached out to me last week about how we can incorporate screening into even our intake. Not that we want any of the MAs to have more things to do, but I shared with her that we were working or eventually with depression screening, it should be able, patients will be able to do it on their mobile phones or cell phones. I'm dating myself with the way I said that, but maybe also being able to have something on their devices too that they could complete while they're waiting for their annual. So anybody coming in for an annual visit, no matter age, anybody coming in for a breast complaint definitely would be, we would have right now what we'll try to do is develop a sheet with a QR code that we put either like on the side of the exam table somewhere in the room. They can scan it with their phone, complete it while they're waiting for the clinician to come in the room so that when you come in the room, it's already completed and we can know their risk. So I was really glad you brought that up too.
I mean,
Um,
that would be great. I think that sometimes you don't know what you don't know, right? And one thing that I have found in a lot of my patients is there might be an entire side of the family that they're not familiar with their history, right? And they may not have access to that, or the person with the cancer may have passed away without testing. So I think some of it is like what you can get elicit from your family, and not all families are forthcoming about cancer diagnoses. But I feel so passionate about this because it's also that not every population is studied in genetic testing. So like there probably are more genes out there that like we just don't know, right? So we know some of them, but we don't know all of them. And I think the wisdom study is a really great way to do an offline assessment. So I often will ask patients to, like, I will just give them in their patient instructions wisdom study. And the wisdom study allows you to join, you answer all the questions. If you are appropriate for genetic testing, they will send you a kit to your home. And then you can get tested, and then they will offer you a personalized risk score. And then you take that back to your doctor and you say, listen, I need to do mammograms and MRIs, or I need to do, I did it and I'm intermediate risk. And so I want to do a breast ultrasound because my breasts are dense, so on and so forth. So it puts some of that back into the hands of the patients, but not every patient has that capacity. But I think it is a nice thing. For me, the ideal scenario is this questionnaire becomes risk assessment becomes part of mammogram because about 80% of the patients in our system do get mammograms, right? So enough people get mammograms and they do answer these questions when they're doing the intake that to like automate that risk assessment into the report is also really helpful. I've seen that at some institutions and I've been actively campaigning to do it here too. And we'll
Yay,
get
that's
there. We'll
actually
get
even
there.
better. Yeah, that's
Yeah.
actually even better.
Yeah. I mean, all ways are good, right? So like our MAs will for our new patients, we have like the questionnaire that goes out for new patients at annual visits, and the patient updates their history offline, and the MAs accept all of those things that the patient has filled in. And so there's no way in a 15-minute visit that they can do a 10-minute history encounter. But like if you move some of that work to their phones, or as they're waiting like as you're waiting, you fill out this questionnaire. It is for your health. Like it's like dedicated time for your health. So yeah, all great ideas, Monica. Thank you.
Does anybody have any additional questions? And Patasha was back there. She was answering all your questions and
I bet.
she nailed them all.
I have no doubt. We are very lucky. We have some awesome nurses and medical assistants.
Well, thank you so much. Thanks for joining us tonight, everybody. And Joanne, thank you always for helping facilitate everything. Have a good night, everybody.
Have a good night. And next is May 9th, May 18th is Dr. Peterson on gestational hypertension and preeclampsia. Stay tuned for more great content from Dr. Christmas's team on Evening Rounds.